welcome to cardiology, but not really cardiology. Welcome to the basis of cardiology, EKG. I am Sue Love, for those of you I have not met. Let me tell you a little bit about this class. So EKGs can be difficult. Matter of fact, probably one of the more difficult things you're going to learn is EKGs. I remember being in primary care, and at least every 6 months I pulled out Dubin's, which is one of our references, and when I would reread it. Because I like the way Dubin's is set up, very simple words, and my brain is fairly simple. And I didn't see enough EKGs in primary care back a long time ago to keep up my skills in EKG. Okay? So this is something that you may see routinely. Okay? I work ER now, and I see 10 or 15 a day, so I'm a little bit more comfortable now. And nowadays we have EKG machines where? Everywhere. EMS, if they bring a patient into you in the clinic who maybe had a syncopal episode, lightheaded, dizzy, and they happen to do an EKG, okay, then you're going to get that from the EMS. Anybody know for EMS what kind of EKGs they're doing nowadays? 12 lead EKGs, meaning legit, right? No longer are they coming in with one lead and saying, here you go, and you're like, oh, I know that. Okay, get nothing out of looking at one part of the heart, right? So as we go through this class, it's going to be super important that if you don't understand something, you come and talk to me about that. Because not only is this important for EKGs, what is it also important for? Cardiology. And guess what your fourth test of cardiology is? A bunch more of EKG stuff. Right? So then we're really going to figure out if you learned anything from this. When we talk about stuff today, we're going to do some really basic anatomy stuff, like super basic, because you learned that as a freshman. Although you may not think you learned it, you did. It's in there somewhere. Okay? We all feel the same way, like, I don't know what I've learned. We all feel the same way about that. We all felt the same way as we ended phase 1 and going to phase 2. Like, what in the hell is going on here, right? So my phase 2, my first rotation was urology. Urology, that was awful. The guy was not nice, the doctor was not nice. We had to go to the operating room. My first time in the operating room, he looks at me and he's like, are you gonna pass out? I'm like, yeah, I think I am. He's like, get out of here, get out of my operating room, don't come back. I was like, oh. And out I went, right? I didn't know anything when I went into that. Or at least I didn't think I did, right? So, you guys have made it this far. Congratulations for that. You will be fine the rest of the time here. You'll be fine in phase 2. As you go forward, it's going to be fine. You may not think so right now, but it will be. But cardiology, EKGs. When we talk about stuff today, if you are a type A personality, and most of us are, that's why we're here, some of this stuff you have to kind of trust what I'm telling you. Okay? Trust what I'm telling you, because the EKG machine is amazing. It does a lot of things behind the scenes that we can't see. The things we're going to talk about today is, why do we have upward deflections on an EKG? Well, first of all, has everybody here at least seen an EKG? Right? So you know on an EKG there's lines, right? There's upward deflections, there's downward, there's straight lines. We're going to talk today about why are those lines there? What makes those lines go up? What makes them go down? What makes them flat? That's what we're going to talk about today. Now, before we start, I do have a little bit of a joke. Why do cardiologists never get lost?
Follow their heart.
They follow the rhythm. Right, they follow the rhythm. All right. Here are our TLOs and our ELOs. Our references. Okay. Do I expect you guys to come to class with all these references? No. But if you have questions, these are the first areas that I would look. Dubin's, like I said, is really good. It's a little orange book, been around for many, many years. Same book I learned for EKGs, like almost 100 years ago, literally. Garcia is really good. Now Garcia is much more in depth. The words are much bigger in Garcia, but they really still do a good job of explaining a lot of things about EKGs. So you can take a look at that. This specific class is based off of Ninja Nerds. I do like Ninja Nerds a lot. The guy takes a lot of time explaining the basic concepts of an EKG. And then I wouldn't really recommend this today, but if you want to look at different EKGs, Life in the Fast Lane, there's a link there. Life in the Fast Lane has a lot of EKGs. The problem is it has a lot of EKGs, meaning EKGs, I'm gonna teach you what it is technically normal for an EKG. There are a lot of things that are still considered normal, but they're on the outside parameters of normal. Okay, so not everything when you look at Life in the Fast Lane, those EKGs, okay, you may say, wait, she said that this is normal, but this say that this is normal too. Yes, there's different versions of normal when we look at EKGs. And why is that? And the majority of the reason why is because body habits. Not everybody is in the military. Not everybody is built the same. And the EKG reflects onto the EKG paper from the electrodes, the electroactivity of the heart, but it's going through the patient's body, through their musculature, through their adipose tissue, through their habitus. Okay, so it's going to change the way some of those normals look. You guys do know this, though. This is everybody, that the heart is located centrally. It's slightly canted slightly to the left. It's behind the ribs. It's behind the sternum, behind the lungs. Okay, but it doesn't sit in our chest straight on. Okay? Again, it's canted slightly to the left, and that becomes really important because the electrical access then is also canted slightly to that. The majority of the people, majority of us, majority of people, the heart is about the size of the fist. Okay? There are things that can change that, oftentimes associated with age, oftentimes associated with comorbidities as well. The right side of the heart is going to pump deoxygenated blood. That deoxygenated blood is going to go to the lungs. Okay, when it goes from lungs, it goes to the left side of the heart, and then the left side of the heart, through the aorta, is going to push out oxygenated blood to the rest of the body. Okay. We know that we have three types of cardiac cells. We've got pacemaker cells, we've got conductive cells, we have contractile cells. The pacemaker cells, they exhibit what we call automaticity, meaning what? They can fire on their own. They don't need an outside impulse to do that. Our conducting cells, the main job of those conducting cells is to get that electrical activity down in through the heart. And then we have our contractile cells that are pushing. Okay? They're going to pump that blood out through the heart and then out to the body. If we look at those pacemaker cells, again, their main function is to set the rate and set the rhythm of the heart. Okay? They exhibit that automaticity. They do not need another cell to depolarize or send electrical activity to them. They can do that all on their own. We primarily see these pacemaker cells in the SA node and the AV node. Now, they can be located in other areas of the heart as well, and I'll talk about that in just a minute. Okay. What is this a picture of? Do you guys remember this from freshman semester? This is an action potential. Action potential. So how do these pacemaker cells work? It all has to do with sodium, calcium, and potassium. Which means if someone comes in and they have a problem with sodium, calcium, or potassium, can affect the pacemaking function of the heart. Okay, someone has a really high potassium, really low potassium, we get super concerned that they're going to have cardiac arrest. Okay, and I've seen it happen in front of my eyes, especially dialysis patients. Okay, so we've got this action potential. And in the action potential, initially we start with sodium. So we've got this slow leakage of sodium into the cell. Because how, in a cell that is resting, that is repolarized or resting, What is the internal of that cell? Is it positive or negative?
Negative.
It's negative. Okay, we're going to start negative. So the pacemaker cell starts at about a negative 60. Okay. We have the opening of these sodium channels called the funny channels. You guys may remember that. The funny channels open, slow rise, which means we're starting to get some degree of depolarization. Once we get to about a negative 40 for the membrane potential, okay, the threshold potential, now we have this sudden increase in calcium. And calcium for these cells is what is responsible for the depolarization to occur. Okay? So again, if something's wrong with the calcium in a person's body, that can affect how these cells are depolarizing. Once we get to about a positive 20, so we've got all that calcium, because calcium is a positive ion, it's going into the cell. Once you get to about a positive 20, now those calcium channels are going to shut. Okay? We've got depolarization that has occurred, and now what happens after depolarization? Repolarization. So in order for these cells to repolarization, we've got to have those calcium channels that shut, and then we've got potassium. Potassium is a positive ion. Well, potassium is going to start doing what? Leaving the cell, because we need to return that cell back down to its resting state. And potassium is a positive ion, so if it stayed in there, we continue to have depolarization. So we've got to return that cell back down to a resting state. We do that by allowing potassium to leave the cell until we get it all the way back down to about negative 60, and then this happens again, over and over and over and over. About how many times for the average person? 60 to 100. 60 to 100 times per minute this is going to occur. We've got those conductive cells. Okay? The conductive cells, remember, their primary function is to transmit that electrical impulse through the heart. And most of the time they're going to do this through the electrical conduction pathway. The electrical conduction pathway is a specific pathway in the heart that allows quick electrical conduction, so we can get quick depolarization of the heart. These cells are primarily located in the bundle of His, the bundle branches, and all the way down to the Purkinje fibers. And they work a little bit different, but we still have the same ions. We still have calcium, we still have potassium, we still have sodium. Okay? But what we start with, we have our resting membrane potential. We start with 0 for depolarization. Here we've got the activation of those sodium channels. Okay? When we think about our pacemaker cells, it was activation of what channels that cause depolarization? Calcium channels. Calcium channels. Okay? So we've got our sodium channels. Okay? We come all the way up to about a positive 20, positive 30 or so for that depolarization. Once we get up there, those sodium channels are going to shut. And now we have some play with calcium channels and potassium channels. Okay? And they kind of equal out. So what we have here is we don't have a sudden repolarization. We have influx of calcium, outflow of potassium a little bit. So they kind of equal out, and that allows for that conduction to occur through those cells. Okay? We slowly go back down, and once we get to about 0 or just maybe a negative 10, now we're going to have that sudden repolarization. And that repolarization is going to occur the same way as we talked about repolarization before, my pacemaker cells, and that's our potassium that is starting to go out, all the way back down to our negative, about negative 90 for our resting membrane potential. We've got those contractile cells. Okay? And they're going to pump the blood. They're going to cause contraction. Now, the interesting thing about contractile cells is they're primarily located outside of the electrical conduction system. They're going to be located in all the rest of the tissue of the heart, the atria and the ventricles and the outside area. And what happens is these contractile cells are actually responsible for myocyte to myocyte, so cell to cell depolarization. They do not exhibit automaticity, meaning that they've got to have an impulse from some other cell that's from the electrical conduction system that's causing them to depolarize. Okay? We still have that influx of sodium That's gonna cause our depolarization. We get up to about a positive 20, those sodium channels are closed. We've got potassium that's going out. When potassium goes out, we've got a beginning portion of that repolarization. And then we have a plateau period. Plateau period is we've got calcium and potassium. Calcium's going in, potassium's going out. And that plateau period is there again for a reason, to allow those cells to finish that contraction. Once they finish that contraction, that pushes the blood out, now they're allowed to rest. Okay? We go through that efflux of potassium, and then we go all the way back down to our resting member potential. Yes?
So the cells have the efflux of potassium. How does it get potassium back?
So it's going out, but some is still coming in. So you have more going out than you have going in for that repolarization, okay? But they're still sliding back and forth by way of how that membrane potential works. So remember, we start with those myocytes negatively charged on the inside. We've got that influx of calcium, we've got influx of sodium, and that's what's gonna cause that depolarization to occur. And ultimately cause the interior of that cell go from negative to positive. We get that cell to a positive, that's gonna cause that contraction to occur. Okay? As that potassium leaves the cell, that's gonna result in repolarization or relaxation of those muscle cells. Okay? All of that works pretty well, and then when we think about myocyte to myocyte, okay, contraction, so outside of the conducting system, that is going to be primarily from sodium via those gap junctions in between the cells. Okay. Once we get to the AV node, okay, at the AV nodes, remember the AV node is the only area that really connects the atria to the ventricles. At the AV node, we have some very special calcium channels. Okay? And those special calcium channels, responsibility is to do one thing, and that is to cause a slight delay. You do not want a direct contraction from atria down to the ventricles. So at the AV node, those calcium channels say, wait, we gotta slow things down a little bit. Why? Why do we care about that? We've got to let those atria contract and then the ventricles. Because if the atria and the ventricles contract at the same time, what happens? Nothing. Nothing happens. You're just pushing blood back and forth in between each other. So at that AV node, we have these specialized calcium channels that say, let's slow things down for just like a tenth of a second to allow the atria to continue to contract. We got that space between the atria contraction, and now the ventricles contract, and we can push the blood out. That electrical conduction system, we have that automaticity, that's going to start at the SA node. Okay? The SA node is located up in the right atrium. Right? So it's going to cause firing of the myocytes in that right atrium, and it's going to cause an electrical conduction that comes not only down to the AV node, okay? We have internodal pathways that go down to the AV node, but also over to the left atrium. Do you guys remember, for the left atrium, what connects the left atrium and the right atrium together? That allows for that conduction to go across over to the left atrium. Bachmann's bundle. That sound like you've heard before? Bachmann's bundle. So almost simultaneously, we're going to have that depolarization of the right atrium and the left atrium by virtue of the Bachmann's bundle. Okay? And then we come down through those internodal pathways, we go down to the AV node. From the AV node, we go down to the bundle of His, which is just below the AV node. Bundle of His down to the bundle branches. Bundle branches down to the Purkinje fibers. And then we're going to go with repolarization after that. So Purkinje fibers are kind of our last little area. And the Purkinje fibers are responsible for depolarization of the ventricles, not only the ventricle apices, but the bases of the ventricles as well. And the bases are going to be up here, kind of more towards where the atria and the ventricles connect. When we look at those bundle branches, the right bundle branch causes depolarization of the right ventricle. The left bundle branch, depolarization of the left ventricle. But the left bundle branch has two branches off of it. We've got your anterior branch and you have your posterior branch. And that is important because something has to depolarize the interventricular septum. And by virtue of the way that that left bundle is innervated, it's the left bundle's responsibility to depolarize that interventricular septum. Meaning if something happens and that left bundle is knocked out, depolarization of the interventricular septum still has to occur, but it has to occur in a different fashion. Going to myocyte to myocyte occurring instead of the electrical conduction system. In a heart that is functioning correctly, the SA node is going to be our primary pacemaker. Do you guys remember why? Let me see, let me count some. Tippet. Tippet, where you at? Okay, oh, right there in the front. Okay, sir, do you remember why, by chance, the SA node is responsible, it becomes our primary pacemaker? Why not the AV node? Why not the ventricles?
Can't remember at the moment.
Okay.
Sorry.
Anybody remember? It has to do with permeability. Permeability to sodium. Okay? The SA node is the most permeable to sodium. And because of that, it fires first. It's like, it's winning the race, right? It's ahead of everybody. It's like, hey, look, I won the race. You go, sir. I won the race because I am the most permeable. And that's only a reservoir. Okay? Meaning, back to this, if we got a problem with sodium, okay, it may not be the primary pacemaker. Something else may take over pacemaking responsibilities. Okay? So the heart has what's called an overdrive suppression. Meaning, if something happens to the primary pacemaker, the heart recognizes there's a problem and says, no issue, I can put something else as the pacemaker of the heart. So if the SA node fails to fire, okay, somewhere in the atria may fire and take over, but most of the time it's going to be atria will be the next place. After that, it's going to be junctional. Now, junctional, I wanted you to put a note on your slides. Junctional is also called the AV node area. But it's not just the AV node. It's the AV node, it's the bundle of His, it's that surrounding area. Okay? So we go SA node. If that doesn't fire, somewhere in the atria can take over responsibility. If the atria don't take over responsibility, it's going to be that junctional area. And the heart rate is going to change depending on what the primary pacer is. 60 to 100 for our SA node, 60 to 80 for our atria. Okay? If it's junctional, 40 to 60. If somewhere in the junction area does not fire, we're down to the ventricles, 20 to 40. 20 to 40. If the ventricles don't fire, we ain't got nowhere else to go. That's it. That's our last chance, right? So we need those ventricles to fire. So you got someone that comes in, 85 years old, I feel lightheaded, I feel dizzy, and they got a heart rate of 30, that should be your clue, something ain't right. Something in this pacemaker responsibility has gone awry, and what is pacemaking this patient? Probably something from the ventricles, based on their heart rate alone. Okay. Now, of course, this can be impacted by lots of things. Autonomic stimuli, so we've got, our flight or fight can get kicked in, and we have an increase in heart rate or decrease in heart rate. Medications, certainly A, B, C, D medications, so beta blockers, calcium channel blockers, adrenergics, all of those can affect the heart rate. Which brings us to how do we assess the heart? What is it? Really simple way of assessing the heart, at least the primary basic function of the heart, is the ECG. And that helps us assess the electrical activity of the heart. Okay, it helps us to be able to evaluate the heart over the period of time, because we can put people on like an extended ECG where we're monitoring them continuously. Okay, it's pretty non-invasive. We just put electrodes on the patient. Sometimes if they're really hairy, we have to shave them a little bit, but overall they tend to be pretty well tolerated. Pretty quick, we should be able to get an ECG in less than a minute on a patient. It doesn't cost a tremendous amount. We have ECG machines everywhere nowadays. So this is going to be your first line tool to evaluate someone that comes in and says they have lightheadedness, dizziness, palpitation. And not only is it a quick and effective way, it provides really good information. It can provide us information about how is the heart functioning right now. Is there any evidence on this ECG that this patient has underlying, uncontrolled hypertension? Can we see that on the ECG? Absolutely, we can see that. Okay? So that person comes in and you're like, excuse me, blood pressure seems to be a little bit high today. Oh no, I don't have a problem with blood pressure. Okay, well, when's the last time you saw a doctor? Oh, like 10 years ago, because I'm totally fine. I don't have any medical problems. I don't need to see anybody. Okay, well, good thing you came in today. Let's go ahead and get an ECG on you, just do some basic labs. And I'm looking at the ECG, and what might tell me that they, in fact, have had long-standing hypertension? Guthrie. Okay, man. What might I see on them? Do you know?
You can see like a pattern for
Left
left ventricular hypertrophy.
ventricular hypertrophy. Listen. Left ventricular hypertrophy. If I see LVH on there, that tells me that left ventricle has been working pretty hard against something, and now it's big, and I can see that on the ECG, and then we have something to talk to our patients about, right? ECGs really have been around since the early 1900s. Okay, William Einthoven, okay, he first developed the first ECG, and what he identified was that electrical activity can actually be felt on the skin. Okay, so you put these electrodes on there, it went through this magnet, this is kind of very rudimentary, had this paper behind there, and his first patient was a frog. And he identified the electroactivity of that frog, and he put it up on this piece of paper. He's the one that came up with our first three leads, lead 1, lead 2, and lead 3. Okay. Now, again, we can get up to 25 lead ECGs if you go to the cardiology clinic. Our primary that we're going to talk about and we'll focus on is either our rhythm strip or our 12-lead ECG. And I've even gotten away from rhythm strips because most of the time you're going to be handed a 12-lead ECG, so you've got to know what to do with that 12-lead ECG. When should we get an ECG? Well, there's lots of reasons. Someone that passed out or felt like they're going to pass out. Okay? Can you have a cardiac cause of syncope? Absolutely. Cardiac and neurogenic are going to be your main causes. So we're going to do an ECG on those patients. If they have dizziness, okay, if they have these palpitations, I'm coming in, I'm complaining of palpitations, let's just do an ECG. Okay? Let's say, let's do this. So you do someone on a piece of paper, they write someone's heart rate down. Say, here you go, Sir Hamilton, here's your heart rate, 80, blood pressure is 120 over 60, O2 sats 100%, temperature is 98.6. Cinema, right? Heart rate's 80, right? But all you know is a number. What did that heart rate feel like? Right? Because we all we know is a number. We don't know, was that right? We don't know because we only have a number. So a person comes in and I felt like, 18-year-old, droopy troopy comes in, weak and dizzy because they were outside. We get these vital signs. Vital signs look great. Is that a reason? Everything looks good. Do we need to do an ECG on this person that felt like they're going to pass out? Yes. Every day of the week. And when you don't do it, that person comes back to you a second time on a stretcher, you're going to be sad. gonna be sad. Just do it. If it enters your mind, should I? You should. Just do it. They're free because you're in the military. Everything's free. Okay. So palpitations, chest pain, shortness of breath, weak and dizzy. I felt like I was gonna pass out. All of those are reasons to get an ECG. An 80-year-old diabetic female with toe pain, that's also a reason to get an ECG, okay? Because those patients are gonna fool you all the time. They're gonna have an MI with toe pain. And so we have very low threshold for obtaining an ECG. Okay? It helps us diagnose arrhythmias, okay? We've got that number 80, but let's feel the pulse. Let's look at what that rhythm is on the ECG. Ischemia, okay? Do I have evidence where the heart is either not getting enough blood or getting zero blood? So ischemia versus infarction. Okay, if someone has electrolyte imbalance, it's 104 degrees out there today. People are drinking tons and tons of water because that's what they make them do in training, right? You cannot do anything until you drink 5 or 10 or 15 canteens of water. Well, what does that push out? All your electrolytes, right? So we can use this to say, look, maybe you're weak and dizzy because you drank too much water, didn't have enough electrolyte replacement, and we get the ECG, and there's indication on that ECG of electrolyte imbalance, okay? It helps us determine, can this person stay here, or do they need to go somewhere else, right? And do they need to go somewhere else in the ambulance, or can they drive somewhere else? So it helps us guide management of these patients. And really, if we can read these ECGs correctly, you think you can save some lives? 100%. 100% you can save some lives, okay? So how do these things work? These machines, how do they work? We have 10 electrodes. Electrodes are the sticky pads that go on the body. Through those 10 electrodes, we can get 12 views of the heart. Okay, 12 views of the heart by way of how the ECG machines are set up. Okay? Now there's a lot of you in here way smarter than me, so I can't explain to you how the internals of that ECG machine work. I don't know. I didn't create it, so I don't know, but I can just tell you the way it is designed for those really smart people is going to give us 12 views of the heart, and that's why we call this a 12-lead ECG. Okay? Each of those 12 leads is going to give us a 2.5-second view of the heart. So depending on how fast or slow the heart rate is, will depend on how many beats you have in that 2.5 seconds. At the bottom of that ECG, we have a 10-second view of the heart. That's called a rhythm strip. Okay. Oftentimes it's lead 2. But like I said, cardiology sometimes have multiple rhythm strips. So we'll have lead 2, lead 1, lead 5. Most of the ones that we're going to see are going to be lead 2 as that rhythm strip at the bottom. So it gives us a good view, a good 10-second view of the heart. Because 2.5 seconds, yeah, we got to have it, right? It gives us a little bit of information. But if we can get 10 seconds, we can determine a lot in 10 seconds. Remember, leads are views, okay, not wires. We got 10 wires going to 10 electrodes. We have 12 lead ECG, 12 views of the heart. We've got 6 limb leads, okay, and then we have 6 chest or 6 precordial leads. So they're going to be our views of the heart. So our limb leads, they're going to be up on our limbs. Okay, we've got lead 1, 2, and 3 are limb leads. Okay, those are called bipolar limb leads, meaning in their electrodes, they have a positive and a negative built in those electrodes for those. And that's how those 3 leads work, by bouncing off the positive and negative electrode. Okay. We have 3 augmented leads, AVR, AVL, and AVF. Augmented vector right, augmented vector left, and augmented vector foot. Okay. And augmented vector means that These are only unipolar, meaning they only have a positive built into that electrode. The ECG machines create the negative that we need, because we still have to have a positive and negative, but it built in the electrode, it only has a positive, and then the ECG identifies with that positive, and it creates the negative opposite that. Our 6 precordial, 6 chest leads, V1, V2, V3, V4, V5, V6, they are also unipolar, okay, meaning that the ECG machine creates the negative that we need. They can only have positive electrodes. And the positive electrode is really important because that's how the heart is viewing, or the ECG machine is viewing the heart from that positive electrode. Each cardiomyocyte within the heart has an electrical charge. Okay? So each little tiny cell in the heart is going to depolarize. Okay? But the ECG machine can't measure those millions of cells in the heart. What it measures is the electrical axis, the primary pull of how that electrical activity is moving through the heart. The sum of those vectors, of those electrical vectors. Okay? That is called the electrical axis. And for the normal person, or the normal heart, the electrical axis is going to go down and to the left. Because remember, again, the heart is canted a little bit to the left in the chest. Okay? So it starts up here at the atria, and the electrical vector is going to go down into the. Why do you think, Moyer? Okay, sir, why do you think that the electrical vector, it goes down and to the left and out, down to the right? Kind of. It is angled that way. That is true. But down and to the left, what do we have down there? Left ventricle. Left ventricle, big or small?
Big.
Big. Big. All right. Left ventricle is big. And because the left ventricle is big, it's got a lot of cells in there. Those cells pull the majority of that charge that way. Okay? That's how it's designed. So if you had somebody that had right ventricular hypertrophy, could our electrical axis change? Could shift over, right? It could shift over. We can see that on the ECG. Patient doesn't necessarily know, but we can see that on the ECG. But that's why it goes down to the left, because the left ventricle is big. Got a lot of cardiomyocytes pulling the majority of that electricity down that way. All right. We're going to go into these different leads and how these leads are going to present on ECG paper. But this is a really important concept that you gotta know before we go forward. If you have depolarization, remember depolarization, the interior of those cells are turning positive. Okay? If you have depolarization, the interior of those cells turning positive, and it is going toward, you have depolarization going towards a positive electrode, on your ECG paper, you're going to have an upright deflection. Upright deflection. Okay? If you have depolarization, okay, so turning positive, but it's going towards a negative electrode, you're going to have a downward deflection on that ECG. If you have repolarization, so the interior of that cell is becoming more negative, 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 and a negative is going towards a negative electrode, just like in math, a negative plus a negative is a positive. There's going to be a positive deflection. If you have repolarization, so the interior of that cell is negative, but it's going towards a positive electrode, it's going to be a negative deflection. And if that electrical activity is perpendicular to the electrode, we'll see a little downward deflection as it goes below the electrode, and then an upward deflection as it goes above. So it goes down and above the main axis line. Right? I like to do this to kind of break things up a little bit, so let's talk about this. As y'all know, on this day in history, in 1781, Los Angeles was founded by 44 Spanish-speaking individuals. 44. Nowadays, how many people live in Los Angeles? more than 44. Okay, 1972. 1970. The Price is Right debuted, but it wasn't really, it was really a re-debut. Anybody know when Price is Right actually first came on air? I'm sure you know. So I'm gonna tell you. What'd you say? No. 1956. 1956. Who was the longest reigning host of Price is Right? Bob Barker, of course, 35 years. Who does it now? Drew Carey. Drew Carey's been there since 2007, so he's been there for a minute. Drew Carey. 1981, this day in history, Beyonce was born. Okay, before she was Beyonce, who was she with? Say my name, say my name. Destiny Child. And then, you know what else they did? Her and her husband, they came out with a new band called The Carters. I didn't even heard of it. I don't know that. And then what's one of Beyonce's most famous songs? Oh, the single ladies. All right. 2002, 2002, that's so crazy. American Idol, first American Idol winner's come. Who was the first American Idol?
Was it Kelly?
Kelly Clarkson. Kelly Clarkson, first American Idol winner. And then sadly, Steve Irwin died. But I mean, really, let's think about that. The crocodile hunter, he lived to 44. That's probably pretty good, considering your name was crocodile hunter. And he died from what? Stingray. Not even, the crocodile is behind the scene going, really? Really? We wanted that. We wanted to kill him. But no, the stingray got him. All righty, so now we got to continue on. All right, we're going to talk about our bipolar limb leads. Lead 1, lead 2, lead 3. Remember, bipolar limb leads, they've got both a positive and a negative. Okay. Lead 1. The positive electrode for lead 1 is on the left arm. The negative electrode is on the right arm. It comes across like this. But I want you, type A people, put your type A personalities away. I want you to not think about, well, wait, it's way up here. How can that even see? No, that's where the electrodes are placed. Okay, the electrodes can be placed here, they can be placed up here. But it still views the heart here in the middle. So bring that electrode down in the middle, and that's how it views the heart. I didn't create the ECG machine, that's what they do. So lead 1. Lead 2, negative electrode on the right, positive electrode on the foot, okay, or left leg is where we put it nowadays. And then lead 3, negative electrode on the left arm, positive electrode on the left foot. Keep in mind that as we go through this, the way that these leads are looking at the heart is from the positive electrode. From the positive electrode and where that positive electrode is at. So we're going to start off and we're going to talk about lead 2. And we talk about lead 2 primarily because it is the lead that, the way that the positive and negative electrode are set, it's most aligned with the normal cardiac axis of the heart, right? Because we have a negative electrode up here on top, we have a positive electrode down here at the bottom, at the foot, at the left leg, and the electrical activity of the heart goes down and to the left. Okay, so that's why we talk about lead 2. And once we talk about lead 2, we'll talk about the other leads, but let's walk through this really slowly so you understand why things look the way they do on our ECG machine. All right, so we've got lead 2, we've got that electrical axis is coming from your negative lead down to your positive lead. Okay? And we know that the SA node is located up in the right atrium. Okay, So the SA node, that's gonna be our pacemaker. That's gonna start things in motion. That's gonna be our beginning of our depolarization. Okay? And the SA node, as it depolarizes, it's gonna depolarize all the cells around the rest of the atria. It's gonna go over to the left atria. It's gonna depolarize there as well. Okay? But the main area, the main electrical axis for this, even though we got all these different myocytes that are depolarizing, the main electrical axis is going to be down to the left, because that left ventricle is also depolarizing. So it's pulling that electrical activity down towards the left ventricle. Okay? So if I tell you that that main electrical axis is here from the SA node down to the AV node, okay, and this is depolarization, so we've got positive cells going down towards a positive electrode. What type of deflection are we going to see on our ECG? Positive towards positive is a upward deflection, right? And what is depolarizing here? The atria, right? Depolarization of the atria are going to occur. Once the SA node fires, it's going to depolarize those atria, right? Going to depolarize the atria. That electrical conduction going down and to the left is going towards a positive. So guess what we have? We have a P wave. P wave is depolarization of the atria, and it's upright because our depolarization is going down towards a positive electrode for lead 2. Okay, we still have lead 2. Lead 2, we still have a negative on up here, and we have a positive down the foot. So negative on the right, positive down the foot. We still have our SA node, we still have our AV node. We're still having depolarization of our SA node down towards our AV node. We're still going down towards that positive electrode. But what did I tell you happens at that AV node? Pause. So if we have a pause, it means we have no net movement of electrical activity. How might that present, do you think? Flat. Flat. We have no net movement of electrical activity, so that gives a flat line. That is called our PR segment. And technically, our PR segment is considered our baseline for our ECG. I mean, we compare everything to that PR segment. When we look over at our QRS complex, our T wave, all that should be at that baseline. It comes back up to the baseline. Okay. All right, let's take a break and then we'll continue on. Slide. We maybe can get a little bit better clarification. All right. This is a negative electrode. This is a positive electrode. If you have depolarization, the interior of the cells are going to be positive, right? The interior of the cell is going to be positive. So the interior of the cell is positive, and it's going towards a positive. Just think about, if I have depolarization, and I'm going towards a positive electrode, I'm going to have an upright deflection. Depolarization towards a positive electrode, upright deflection. If I have depolarization towards a negative electrode, it's going to be downward deflection. Okay? Remember, when we think about repolarization, the interior of the cell now is becoming more and more negative. So more negative. It's flipping from positive, negative, negative, negative. So anytime you have repolarization, and it's going towards this is your electrode, going towards a negative electrode, because the interior of those cells are becoming more negative, then that is going to be your negative plus a negative is that positive, and that repolarization. And really, there's only one area of on the EKG that we'll talk about repolarization, because that's what indicates repolarization is occurring. There's a T wave. Right? Perpendicular, don't worry about perpendicular as much, but if you see something like this, it tells you, if it goes down and up, it just tells you that the electroactivity is in line with that electrode. Right? It's in line, that just is your indication that it's in line with that electrode. All right. So let's continue on and see if we can, as we go through many of these, hopefully we can kind of understand how these positive and negative electrodes are going to impact what we see on EKG. So we've got our P wave. P wave indicates that depolarization of the atria, okay, both the right and left atria, because they depolarize almost simultaneously. When you have a problem with one, either the left or right atria, you will see, with depolarization, you will see that in your P wave. Sometimes you will see a P wave that looks like two humps, okay? And that is because they are not depolarizing at quite the same speed. They're depolarizing a little bit differently for some reason, okay? Maybe one's bigger than the other, it's pulling more electroactivity. But in a normal ECG, we see this nice rounded hump. It's kind of signifying that we have almost simultaneous depolarization of both the right and left atria. Okay. So at the AV node, we're going to have that slight delay. Because we have no movement of electroactivity, that slight delay is going to be a flat line. And again, that is our PR segment, also known as our baseline. All right, so we've got our SA node. Our SA node is here. We are pulling electrical activity. Our electroactivity is coming down here. Now that electroactivity, when I say that, I mean depolarization. We are depolarizing from the atria, trying to get all the way down to those ventricles for our depolarization. So we have depolarization. The interior of those cells are becoming positive, okay, as we have that influx of sodium or have that influx of calcium. And that positive, those positive cells are going down towards this positive electrode that is down here. Typically, we'll put it down here kind of on the upper portion of the hip is where it goes, or even on the lower abdomen. Okay? So we've got that occurring. Once we do that, we've got our P wave, okay? Because we're going positive, meaning depolarization, down to our positive here, gives an upright reflection of our P wave. We've got that slight delay at the AV node to allow a difference in contraction from the atria to the ventricles. That's going to give our flat line. Okay. The next thing that has to occur is we have to have depolarization that is going to slide beyond that AV node down into the bundle of His and down towards our right and left bundle branches. Remember again, left bundle branch has two bundles off of it. We got the anterior branch and you've got your posterior branch. Okay. Let's move over here. So we've got that bundle of His. We're going down to our left and right bundle branches. Okay. And because that left bundle is responsible for depolarizing the interventricular septum, I've got the arrows here saying we're depolarizing left to right. We are depolarizing left to right. We've got our positive here. We've got our negative here. We are depolarizing right now, left to right. So which way are we depolarizing? Are we depolarizing towards a negative electrode or are we depolarizing towards a positive electrode?
Negative?
Negative. Put your type A personalities away. Okay? Negative-ish. Right? We're going that way. We're not going this way down here. We're going this way. Is it going directly up towards the negative? It's not. But it's going that way, towards where the negative electrode is. If we say the negative electrode comes here, and the positive on this side, we are going towards the negative. So depolarization towards a negative electrode gives us what type of deflection?
Down.
Because we have positive going towards a negative, so because depolarization gives us a downward deflection. Downward deflection. Okay, positive, which is your depolarization, going downward deflection, and this is our Q wave. Q wave represents depolarization of the interventricular septum. Many ECGs, you will not see a Q wave. Okay, we will talk in another lecture about what is important about a Q wave. Okay, what is significant about a Q wave, because when they are there, they could be normal, or they could indicate an infarct. It could indicate that someone is having a heart attack right now. So you've got to be able to determine the difference of, is it important or not important? Many ECGs, especially young healthy people, you won't see it. If you do see it, it is depolarization of the interventricular septum. All right, so we've got that septum that is depolarizing. The next thing we do is, once that septum is depolarized, we still got our SA node coming down to our AV node. We're still going down, still talking about lead 2, going down towards that positive, which gives our upright deflection. That slight delay at the AV node gives us our flat line, no net movement of electrical axis. Okay, we've got our QA, which is depolarization towards the left to right depolarization. I said towards left, and left to right depolarization. Okay, the next thing that has to depolarize are our ventricles, the apices of our ventricles. Think about the ventricles as a whole, but they're also kind of, the depolarization occurs a little bit different. So we've got our apices of our ventricles that are going to be the first to depolarize, and that's the majority of the ventricles. Again, we've got lots of myocytes that are depolarizing. A lot of the Purkinje fibers are depolarizing. So they're going to pull some of that electrical activity down. Okay, the right ventricle, that is depolarizing. The left ventricle is depolarizing. But look how much bigger that left ventricle is. That left arrow is like, hey, I'm really pulling this out. But the right ventricle says, I'm pulling some too, so we're going to go kind of in the middle. Okay, down and to that left. Okay. So if I have depolarization that's coming really down here in the middle, because we equal out the electrical axis, down here, is this pointing towards the positive or towards the negative? So we have depolarization, it's going down towards a positive electrode. What inflection am I going to see on my ECG? We're going to have an upward deflection. And it's a big one because these are the ventricles, and the ventricles are big. That is our R wave on the ECG. Now, does anybody know why is our P wave rounded, but our R wave is straight up and down? Like almost should have come up quick. Why is our P wave rounded? You gotta look at it. And our R wave is a because of the amount of electrical activity that the ventricles are pulling. Okay, the atria are small. Atria are really small, and they don't have as much electrical activity that they're pulling, right? So they're going to kind of create this rounded area. But the ventricles are big, and they're pulling that electrical activity straight down and then pushing it out. Okay, so we're going to have that big, long, tall deflection in our R wave that indicates that the significance of the pull of those ventricles. Okay? Again, which will become important because if we have a really small R wave versus a really big R wave, okay, that will tell us that, hey, something's going on with those ventricles. Why is my R wave 15 boxes high? Okay, why is it so high? Something is causing that ventricles to pull even more, right? So that is the depolarization of our ventricular apices is going to be our R wave. Okay, so now we've got to get depolarization, and we've still got our SA node that's coming down towards our AV node. We've got our depolarization that is going down towards our positive. We've got that slight delay at the AV node. We've got our bundle of His. We go down to our left bundle, and we've got all the way down to our apices of the ventricles. All of that depolarization is occurring, and we've got our R wave. The next thing that has to depolarize is our ventricular bases. Okay, so we're coming back up the size of the ventricles so we can get the rest of the ventricles to depolarize. Okay, we got Purkinje fibers all the way up there. So we're depolarizing up here, we're depolarizing here. Okay? Depolarizing still. If I'm depolarizing here and I'm depolarizing here, is that going towards the negative or towards the positive?
Negative.
It's going towards the negative. So now I have depolarization, means I have positive cells, but they're going towards a negative electrode, what kind of deflection am I going to see?
Downward.
Downward deflection. Downward deflection. Because we have positive cells, because our depolarization goes towards a negative electrode up here. If this was a positive electrode, it would be different, but it's a negative electrode, right? That is our S wave. And S wave represents depolarization of the ventricular bases. Okay, depolarization of the ventricular bases. All right, so let's start from the beginning. We got our SA node all the way down to our AV node going towards the still lead 2. Going towards our positive electrode node down here. We've got that positive deflection of our P wave. No net movement at the AV node for PR segment. We've got our Q wave, which represents a MOA. A MOA. Okay, what does our Q wave represent, sir? Septal depolarization. Ready? An intraventricular septal depolarization that occurs from the left bundle and is depolarizing over towards the right. Okay? Got that Q wave, and then we've got the depolarization of the majority of the ventricles, which is why that R is so big, and that's the apex of the ventricles, and then we've got that S wave. S wave is not as big because it's just a little portion of the ventricles that are depolarizing up there, the ventricular bases. Okay, what happens now? What happens now? Where do we go? Repolarization. Repolarization occurs. So in between depolarization and repolarization, we have no net movement. We got to rest for just a split second. So if I have no net movement, what is my next line going to look like?
Flat line.
Flat line. It's going to look like a flat line. That's our ST segment. ST segment represents the time between depolarization and repolarization. And it should be flat. Should be flat unless there's something going on that's affecting that time between repolarization and depolarization. Okay, very good. So we've got that going. Now, the next thing that we have to talk about, we talk about our P wave going down, we've got our PR segment. Okay, that's our time at the AV node that we're just resting a little bit. Q wave, we've got our R wave, we've got our S wave, and now we have our ST segment between depolarization and repolarization. Okay, so now we are ready for repolarization. When we have repolarization occurring, the interior of their cells are going from positive to negative, right? Because we are going back to our resting state, right? So we've got positive cells. Now, everything right now is all positive, but it's going to start to flip. Start to flip to those negative interiors, okay? So repolarization is going to go back up this way as we're flipping back up the ventricles all the way up to the atria, because that's how that repolarization occurs. Back up the heart. Okay, so if we have positive going to negative, so all these negative cells, and we're coming up this way with these negative cells for repolarization, what kind of inflection are we going to see?
Upward.
Negative towards a negative is a
Upward
positive.
deflection.
Positive upward deflection, right? So again, we got those positive cells. Those positive cells are going away. We're changing to negative, and we're going negative towards a negative electrode. Is going to give us a upright deflection. That upright deflection is that T wave, and the T wave represents repolarization. Bless you. T wave represents repolarization. All right, so here's what we got. We put it all together. We've got that P wave. P wave represents atrial depolarization. Both the right and the left atria are going to depolarize. And in lead 2, it's going to be an upright deflection. We've got our PR segment, which is that period at the AV node, where we do not have any net movement of electrical activity. So we're going to have a flat line that represents PR segment, also known as our baseline for our ECG. Once we have our PR segment, we're going to have depolarization of the interventricular septum. And for lead 2, that depolarization is going towards a negative electrode, which is going to be a downward deflection. The next thing we have is depolarization of the ventricular apices, okay, which is the majority of the ventricles. And because we have that depolarization that's right in line, going right down, right towards that positive electrode, we're gonna have a positive inflection. And then after that, we have the depolarization of the ventricular bases. Okay, that's just a little part of the ventricle, so that S wave is really small, and that represents depolarization of ventricular bases. We are now time for the time period between depolarization and repolarization. No net movement of electrical activity, so that gives our flat line. And then we end with repolarization for lead 2. Repolarization is going back up towards a negative, and deep repolarization is negative interior cells, and that gives us a positive inflection, because negative plus a negative is positive. Okay, for lead 2. Let's do a knowledge check here. AV node. If AV node is pacing, what AV node is AKA what? Junction. AKA junction. If AV node is pacing, what might the heart rate be per minute? Heart rate
40 to 60.
40 to 60. 40 to 60. Which of the following ions is responsible for cell to cell? So myocyte to myocyte depolarization. Sodium, myocyte to myocyte. Okay? Which of the following has the fastest pacemaking function? SA node, most permeable to sodium. And then the cardiac cell polarized in the normal resting state with a positive internal charge.
True.
False. Resting, negative, resting. RR, right? Resting, negative, and that is going to be repolarization. Okay. You got a 78-year-old female. Let me see here. Patterson. 78-year-old female come in unresponsive. Heart rate is 38. That's all you know. That is all you know. Where do you think that her heart rate is being paced from? The ventricles, right? Because what is our rate for the ventricles? 20 to 40. So heart rate of 38, concerning, right? Concerning. Probably coming from the ventricles. We got to figure out why didn't the atria take over? Why didn't the the junctional area take over? Why are we all the way down to the ventricles before we finally got a pacemaker to take hold? All right. Bipolar limb leads, lead 1, lead 2, lead 3, they have a positive and a negative. Again, don't think about lead 2 as being way over here. It's coming right straight down through the middle of the heart, aligned with the normal cardiac electrical activity axis of the heart. Okay? Don't think about lead 1 being way up here. Lead 1's going to come down. It's going to look through the middle of the heart with your positive on the left and your negative on the right. And the same thing for lead 3. Lead 3 is going to come over, and your negative is going to be up here, and your positive is going to be here. And wherever your positive electrode is at is what part of the heart that electrode is primarily looking at. We talked about lead 2. Let's talk about lead 1. Lead 1 is bipolar, so it has that positive and the negative. Remember lead 1, our negative is going to be on the left. Our positive is going to be on the right, and they're both going to be up here on the arms. Okay? So I've got arms, you can put it down here, you can put it here. There's all different ways of putting those electrodes, but they've got to be that way. It has to be negative on the left, it has to be positive on the right. So if we go from our SA node down to our AV node for depolarization, SA node's here, AV node's here, and coming down here, are we going towards a positive or negative for our depolarization? Positive. Meaning we're going to have what type of inflection? Upright inflection. P wave. Still representing atrial depolarization. Okay, so now we go from that AV node, whatever. We have that AV node, we know we don't have any net movement for a tenth of a second. Okay, so we still have a PR segment even in lead 2. We still have a PR segment. Okay, after our PR segment, the next thing that has to be depolarized is what? Interventricular septum. It's still going to occur the same way. It's still going to go left to right. Okay, it's going to occur left to right, coming this way. So is that going towards a positive or a negative?
Negative.
So here's the thing, right? So we're going towards a negative, right? So we've got a positive here. Our depolarization is going towards a negative. Those interior cells are positive. They're going towards a negative, which is going to give us a downward deflection. That is our Q wave. Okay, Q wave. So after we have our Q wave, what is our next thing that's going to depolarize?
Ventricle.
The big portion of the ventricle, the ventricular apices. The ventricular apices. All right, so now we know we've got this depolarization here, but now depolarization is going to continue to come down this way, down towards that left ventricle, because that is the normal electrical axis of the heart. Okay, the normal electrical axis is down towards the ventricle. Just because we change where our positive and negative electrode doesn't mean we change the electrical activity of the heart. It's still going the same way. It's just how those electrodes are picking that electrical activity up. So if we're coming down and to the left, okay, is that going towards a positive or towards a negative electrode?
Positive.
It's going towards a positive electrode. So we've got that big R wave that we're going to see. That big R wave that we're going to see as part of that depolarization of the ventricular apices. Okay, next thing we have is depolarization of the ventricular bases. So just this part here and this part here. Okay, and this is where you really got to put your type A personality away. But if we come up here and we say this kind of, if we have it should be canted a little bit. Okay, and this is coming this way, and this is coming this way for depolarization. Okay, trust me when I say it's going towards the negative. Okay, because we're canted a little bit, it's going towards a negative. So what you're going to see with our S wave, okay, you're going to see that negative deflection for lead one as the ventricular bases get depolarized. Okay, and yes, I understand that one's a little bit more tricky. Okay, but that's one of those, trust me when I tell you that is actually what happened. All right, now we have the time period between depolarization and repolarization, which is going to be our flat line, no electrical movement. Okay, now we have repolarization. Repolarization is coming up this way, up this way. Repolarization means the interior of those cells are becoming more negative. If we have negative coming up this way and negative come up this way, is that going towards a negative or towards a positive? It's going towards the negative. Okay, it's going up this way. It's not coming this way towards the positive. So it's going towards a negative. A negative going to the negative gives you what type of deflection? An upright deflection. Wow. Interesting. Okay, let's talk about lead 3. Talk about lead 3. Lead 3, we have a negative on the left and we have a positive on the foot. Wait a minute. Have we seen something similar? Did lead 2 have a positive at the bottom and negative at the top too? It did. Negative may have been on the right, but it's still negative is on the top and the positive is at the bottom. Okay? So go back through this then. SA node down to the AV node. Okay, we're going right straight down here towards this positive. We're having depolarization, which is going to give us that positive inflection of our P wave. If we come down to our AV node, we've got that slight delay. We know that's our PR segment, no net movement. Next thing is going to depolarize is the interventricular septum. It's going to depolarize down here. It's going to go this way. Okay, well really it's actually going to go like kind of like this. Okay, so if you have positive and we're going this way, and again, this is one of the like, there's nothing over there. What do we do? It's going this way. Okay, your negative is going to be up here, your positive is going to be down here, and it's going up this way for depolarization. So it's actually going towards a negative, which is on the top part of the heart for that electrode. Okay, so that's going to give your positive towards a negative downward deflection. And next thing we have is our depolarization of the ventricular apices. Coming down here for our depolarization, this makes it a little bit easier, going towards a positive, which gives us that big giant upward deflection. What do we have after that? Depolarization of the ventricular bases. Okay, if we're coming up here, and we're coming up here, and we've got depolarization that's going this way and this way, what do we think that's going to give us? A downward deflection, because we have that negative that's up on the top. So that gives us that downward deflection. And then we've got our time period between dipole and repole, flat line, and then our last thing is going to be that T wave. Is a T wave upright or down going? Who says upright? Yeah, because we have repole coming up this way, repole coming up this way towards up here towards the negative part, okay, and that's going to give us upward deflection. So if we look at lead 1, lead 2, and lead 3, we're pretty lucky, because they should all look very similar. They should all look very, very similar. What you're going to see on an ECG is a difference in amplitude. In amplitude, I mean, how high does the P wave go up? How high does the R wave extend, or how deep does the S wave? That's what you're going to see in the difference. But the P wave should be upright. The Q wave should be down going. The R should go up. Okay, the S should go down. The T should go up. Okay, maybe it's box or two difference, but that's how each of them should look. And again, we're talking about truly normal. Truly normal. Right? And how do these leads then look at the heart? We look from the positive electrode. So if lead 1, we say the positive electrode is on the left and the negative electrode is on the right, then lead 1 is going to look at the left side of the heart. Okay? For lead 2, we said the positive electrode is down at the foot and the negative electrode is on the right. It's going to look at the foot, or the inferior portion of the heart. And then lead 3, positive electrode is down at that foot again, negative up on the left, and that's also looking at the bottom portion of the heart. Okay. So lead 1 lateral, lead 2, and lead 3 inferior portion of the heart. Alrighty, what do you guys think about this? Homan. Jeffrey Homan, where are you? He's gone? He's not here? You guys lying? I'm trying to get an answer to the question. All right, Scott McMillan, you're next then. Okay, sir, what do you think? True or false? False. Heart disease affects only older adults? False. False, right? Can someone in their 20s have heart disease? Yes. Sure. I saw a guy in Uvalde, 23 years old. I forget what he came in for, but we had to draw his blood for something. We drew his blood, and there was this much blood and this much fat. His triglycerides were in the thousands. Thousands. He probably has heart disease. He's going to have it very soon at least, right? So false, right? Up to 10% of heart attacks can occur in people under the age of 45. All right. All right, let me see here. Oh, gosh. Quinchard? Is that even close? Huh? A guitar? Guitar? I'm gonna call on you once. Okay. Cardiac arrest and heart attack, same thing? False. What's the difference?
Cardiac arrest is electrical issue, and then heart attack, the blood flow stops.
So cardiac arrest, gone, right? We might be able to bring them back though, but their heart stops completely, right? For a variety of reasons. And then heart attack is that area of the heart loses blood supply, usually from a blockage. So something is causing that area not to get blood supply, usually it's a blockage. All right, so not the same thing. Okay, and then one more, Halverson. If you smoked for years, you can't reduce your risk of heart disease by quitting. False. That's right. It is false. Matter of fact, the minute you stop smoking, it already reduces your risk of heart disease. Within 10 years of stopping smoking, your risk for heart disease is back to normal. Okay? Risk for heart disease is as if you never smoked. And that's important when we talk to our patients about stuff. Oh, there's nothing, doesn't matter if I stop now. I've already been smoking for so long. It's not going to make a difference. No, it makes a difference as we talk to our patients about that stuff. Okay, let's go on to our augmented vector leads. Remember, augmented vector leads are unipolar, meaning they only have a positive. The rest of it's up to the ECG machine. So we're still going to have a positive and a negative, really. Okay? And how that happens doesn't matter to you. It may matter to you, but I'm not going to tell you how because I don't know. I can just tell you that the ECG machine does the work for us. But we're still going to have it positive. And if we do augmented vector right, it's going to give us a positive electrode on the right and a negative electrode over here on the left side of the heart. So positive here, negative here. Now, let's think for a second. Lead 1, positive, negative. Lead 2, positive, negative. Lead 3, positive. Have we had anything with a positive over here yet?
No.
We haven't. We haven't. Okay, but we'll still run the same game here. We got SA node that's going down to the AV node. You have your SA node going down to the AV node, and I'm telling you that the EKG machine is putting your negative over here. We have depolarization that's still going down that same electrical axis. We're depolarizing towards a negative, which is going to give us a downward deflection. Okay? Let's think about what happens next. Guess what? We still have a PR segment. Still going to happen the same, no matter where those electrodes are placed, we still get that slight delay at the AV node, which is going to be our flat line, also known as our baseline. Okay, what about the next one? What's our next thing we're going to have? After our AV node, we have depolarization of the interventricular septum, right? Okay, so if we're depolarizing that septum, and we're depolarizing this way, going towards a positive or a negative, going towards a positive, so we have positive cells depolarizing, going towards a positive, we're going to have a upward deflection. So now our Q wave's up. Okay, all right. And it would come back down to baseline too. All right, so now once we do our interventricular septum, we've got to have depolarization of our ventricular apices down here. It's coming this way for depolarization. What kind of deflection are we going to have? Downward. Big downward. Okay, so come back to baseline. We've got our R wave. R wave will come back up here to baseline. We've got ventricular depolarization of our ventricular base is up here, coming up this way, coming up this way. What is our S wave going to look like? Up. Everybody good with up? We're coming back this way. So our S wave is going to be up. So we'll actually come up here to baseline. And then most of that S wave is going to come up above this baseline and then back down to baseline. After our S wave, that represents the end of our depolarization. We're still going to have that ST segment, which is a time frame between depolarization and repolarization, that flat line. And then the last thing we have is our repolarization. Flipping of those positive to negative cells so they can rest for a half a second, right? Or a millimeter of a second. So if we have repolarization, we're coming back up this way, negative towards a positive. What do we have?
Down.
Downward deflection. Downward deflection. So just when you thought you knew something, you actually do, right? But things are different. Things are different, but you recognize, hey, wait, my positive is not where I'm used to seeing it, and everything is opposite. In AVR, that is the truth. Everything is opposite of what you thought you knew to be normal, but for AVR, that is normal. Okay, that's because of the way the electrodes are placed. Okay, AVL, positive here, negative, we're placing a negative on the opposite side, okay? Have we had anything else that had a positive over here?
Yes.
Lead
Three.
one. Lead one had a positive over here. Lead three had a positive down here.
It's four.
Lead, it's, it's almost 5. Lead one had a positive. So that tells us that we've seen this before. We've seen this before because of why we know about those electrodes. Okay, we go down to our SA node, down to our AV node, we get that positive going down here, it's going towards that positive. So we've got an positive inflection of our P wave, our PR segment is still going to be flat, our Q wave, we have a depolarization of the interventricular septum that's going this way towards a negative, so that's going to be positive towards a negative, which is going to be downward deflection. Depolarization of our intraventricular ventricular apices is going to be down this way. So down over this way, not this way, but this way, which is still positive. Gives us that positive inflection. Depolarization of our ventricular bases is going to be up towards our negative, downward deflection. We still have our ST segment, and then repolarization is going to be up this way towards our negative, negative towards our negative is going to be that positive inflection. So AVL looks similar to leads 1, lead 2, lead 3. So now we got that one plus AVL, similar. Okay, what about if we look at AVF? Is there anything that we've had that has a positive electrode on the foot and a negative electrode that's being created up here?
Yes.
2 and 3. 2 and 3. 2 and 3. Both have that positive down below. So again, we're going to run that same situation where we're going towards that positive. Okay? So all of that stuff remains the same as what we saw in 1, 2, and 3. So 1, 2, 3, AVL, AVF, all look the same. The only outlier is going to be that AVR. So how do our augmented leads then look at our heart? We're still looking from the positive electrode. We know for AVR, our positive electrode is on the right side. So it's actually looking at a bit of the right side of the heart. And that it can look through and give us some information about the top portion of that septum as well, the interventricular septum. AVL is on the left side. Our positive's over here on the left side. So it's going to be looking at the lateral side of the heart, the left side of the heart. We call it the lateral side. Okay, and then our AVF, AV foot, is looking at the inferior portion of the heart. So we've got our limb leads now. We've got our 6 limb leads. We've got 3 bipolar limb leads, which is 1, 2, and 3. We've got our 3 augmented limb leads, which is AVR, AVL, and AVF. How many electrodes are we using to look at these 6 views? 3 electrodes to look at those 6 views. It's amazing how those EKG machines work. Okay? It's amazing. So we're using 3 electrodes. We've got an electrode placed here on the right, an electrode placed on the left, and we have 1 electrode placed down here. Okay? For those 6 views. And all of them look like this except for which lead? AVR. AVR is the outlier of those 6 leads. Okay. When we look at the limb leads give us a frontal view of the heart. So it gives us this plane of the heart. Okay. And again, we look from the positive electrodes. We know AVR is looking at the right and then the top part of the interventricular septum. AVL is looking over at the lateral. 1 is looking at the lateral. 2, 3, and AVF are giving us information about the inferior portion of the heart. Let's talk about our chest leads. And the easy thing is we have 6 chest leads with 6 electrodes. Okay, so we don't have to worry about that math with that one. 6 chest leads, 6 electrodes. So we have 6 chest leads, 6 electrodes. Okay, and then we have 3 limb leads, or 6 limb leads, 3 electrodes. So right now, how many electrodes do we have? 6 plus 3, 9.
Rhythm lead.
Where's our electrode?
Rhythm one?
Well, the electrode goes on the right leg. But it doesn't do anything on the EKG for us. It is there for, because of the iPhone, really. Meaning, we have so much electricity in the air around us, it's there for interference. So we must have it, but it's not projecting anything on the EKG machine. But if you don't have it, you won't get anything on your EKG paper, okay? So it's there for interference. All right, our chest leads. Chest leads are placed around the heart. It gives a horizontal view of the heart, and it's placed around the heart in the 4th and 5th intercostal spaces. We've got V1 that's located on the right sternal border between the 4th intercostal space. How do you know what's the 4th intercostal space?
Nipple.
Anatomic wise.
Nipple?
Nipple line for men and from mammary line for women, okay? That's gonna be your 4th. Go left sternal border, 4th intercostal space is gonna be your V2. We're gonna skip V3 for now. We're gonna place V4. V4 is gonna be 5th intercostal space. Okay, so we have 2 at 4th intercostal. We're going down to our 5th intercostal space, and it's gonna be mid-clavicular line, so just below the inframammary line. And patients, if you can feel their ribs, really try to put it in between those ribs. Okay, once you place V4, now go back and place V3 somewhere halfway between V3 and V4. But V3, okay, is going to be ideally still in the intercostal space. Okay, usually at the bottom portion of that 4th intercostal space. Okay. Then we're going to go to V5, which is going to be 5th intercostal space, mid-axillary line, and then V6 is going to be 5th intercostal space, mid-axillary. I said anterior axillary line, and then 6 is mid-axillary line. So anterior, and then mid for 5 and our 6. And because the chest leads give us a horizontal view, okay, we're going to primarily focus on how it changes our R to S ratio and how we can see our R to S on those chest leads. Our P wave is still going to be the same. It's going to be primarily upright. We're still going to have that PR segment. Okay, that's going to be a flat. We're still going to have the conduction or the depolarization of those atria, and that's going to show on. As we transition then to ventricular depolarization, because of how this looks at the heart in a horizontal fashion, like directly through the heart, we want to focus on what our R wave and our S wave should look like. So P wave, PR segment, ST segment, T wave are all going to look like we saw in leads 1, 2, 3, AVF, and AVL. But what's going to change is that these are our R wave and our S wave. So we have our positive, these are only unipolars. We have our positive electrode here, and it'll create our negative electrode. But when we look at how these are aligned with the left ventricle, will tell us how our R wave and our S wave are going to look. Okay? So we've got the right ventricle that's pulling some of that electrical axis, the left ventricle that's pulling some, but down the middle is really primarily what we're going to get. Okay? So we've got same electrical axis like we are used to. And because of how these are located on the chest, we have V1 that's really overlying the right ventricle. We've got V6 way over here that is really on the primary portion of that left ventricle, V5 and V6. So if you have V1 that's over here primarily over the right ventricle, what you'll see in that R wave is a really small amplitude, because that R wave represents depolarization of the ventricular apices, which is the major portion of the ventricles. But we're not really capturing it all that well with that V1. So we expect to see in V1 a small R wave. That being said, when we think about depolarization coming back up this way, okay, do we think that the S wave is going to be small, or the S wave might be a little bit bigger if we're going depolarization back up across these ventricles? A little bit bigger. Okay. So V2, our R wave's a little bit bigger than we see in V1 because it's getting closer and closer to that left ventricle. V3 is right on the cusp of that left ventricle, so it's going to be upright, and our S wave will be downward about equal. V4 is over just to the right of the midline of that left ventricle. V5 and V6 overlie the middle of that left ventricle. And that's where we see much higher amplitude in V5 and V6 of our R waves. Okay, our S waves for these, okay, because of our negative is going to be up here, our S wave is going to be more prominent in V1, okay, a little bit less prominent in V2, and as we go all the way from V4, V5, V6, V5 and V6 oftentimes don't even have an S wave at all, because they can't really capture it the way that the electrodes are placed. So in those chest leads, what you're looking for, okay, is you're looking for this R/S wave progression. This is our normal R/S wave progression, where we have a very small R wave in V1, a little bit bigger in V2. V3 tends to be perpendicular, so we call that equiphasic, so same above and below. And then V4, V5, V6, much more prominent R wave, little tiny S wave, and then you can see V5, V6, oftentimes just a ditzel of an S wave if you see an S wave at all. You must know this. You must understand that this is normal progression for your R and S wave. Okay? You will have a question on the exam, and multiple things that we talk about, when we talk about hypertrophy, that talks about this R S wave progression, and even Access talks about R S wave progression. So you gotta know this. Okay? So we look at how these chest leads, precordial leads, look at the heart. V1 and V2, they're going to look at the septum of the heart and a little bit of that right ventricle. Okay? So remember, AVR also looks at that. V3, V4, anterior wall of the heart. And 5 and 6 is looking at the lateral wall of the heart. Okay? So this is all of our leads together. We've got our precordial leads and we have our limb leads. AVR, out here looking at the right and the top portion of the septum. AVL, and lead 1. And 5 and 6, all of those look at the lateral portion of the heart. AVL kind of looks at the high lateral, the rest look at all considered to look at the lateral portion of the heart. And then V1, V2, they look at the anterior, or the septum, V3, V4, anterior, and 2, 3, and AVF, the inferior portion of the heart. So how are these placed? We have to talk about it tomorrow. Have to talk about it tomorrow. Our time is up.